So next I invite Dr. ANAND PARTHASARATHY to talk on deciphering the DESCEMET'S.
Thank you, Gayatri, for inviting me to be here. And I just want to tell this IC was discussed over 5 minutes in the airport, and then we decided to submit it. All right, this is one of my cases wherein we did a DALC in the big bubble technique, and intra-op we were able to bear the decimates, and post-op the sutures were in place. Post-op, I realized there was an area of edema. Since the vision was very good, we decided to just leave it and observe. And the video of the OCT shows that that area of detachment which was there is not very much, it's not extending, it is continuous. So we decided to just observe. So the corollary is that the amount of Descemet's makes a difference. This patient was a 12-year-old with a sudden drop of vision, acute hydrops as you can make out, and on the OCT you could make out very, very significant edema, discontinuity of the Descemet's, large fluid clefts across the whole cornea, and this required a slightly different management. Now, the pearls for DMD management include the time, whether it's intra-op, whether the patient is presented early within the first 3 weeks or late, more than a month. The extent of the DMD is important because peripheral DMD, small DMDs, the shape of the DMD makes a difference. And if the visual axis is involved, then you would probably intervene early. ASOCT is of course preferable if you have that, in addition to a good slit lamp examination. Probably important to just mark it on your case sheet because this is important OT because sometimes you flip and you got an inverted view intraoperatively. This is a nomogram which I borrowed where you have basically two options, conservative and surgical. Conservative, basically hypertonic saline, not very effective. Steroids probably a better idea. Surgical in terms of use of descemetopexy, which I'll elaborate more on, where you can use air, you can use 4% C3F8 or 20% SF6 for tamponade. You can do suture fixation with full thickness sutures. You can do a descematotomy where if there is significant scarring and there is a lot of folds on the descemetes, and of course in very severe cases where nothing can be done, you're probably looking at a keratoplasty. A short video just to demonstrate the shape, and this is a video by Dr. Megur, where you can see on the side port there is a fluttering descemetes, which is it's a very triangular with a very shallow apex. So these DMDs don't really require much to be done. Most of the time you can leave it. There would be an endothelial sliding. Of course, you got to make sure you do not extend. The reason I tell you is marking is preoperatively, it's important if you're taking this patient up for treatment. This one other point from Vikas, which is basically in terms of pre-op examination, where you need to do a good pre-operative examination, and there are some small intraoperative hacks and post-op management which is elaborated. Basically, if it's a very large detachment which is extending limbus to limbus, which is present on the OCT, you're probably looking at a surgical intervention wherein you would need to take the patient back to OT. Epithelial debridement is a good idea, basically for better visualization. And what you would probably need to do is to know which is your attachment, which is the area of attachment through which you need to actually enter the anterior chamber. And once you have the clear area, in this patient, the attachment is more on the right side, the temporal side, and you got to make the port which is far away from the area of insertion. You got to make sure you have not entered the you're under the descemet. So touching the IOL is a good idea. If there is a PCIOL, you need a full airfill. If it's this amount, an option is to use SF6, or you can use air if you feel that it's a continuous and it's a very early detachment. So early detachment, air may be preferable. If there is not significant interface fluid, you're sure there's no viscoelastic in the interface, a gentle stroking usually is a good idea. You can take back the patient 2 hours later, do a burping of this amount of air. Since you got a full air fill, leave about 50%. This is basically to avoid pupillary block. Now, when you have large onset detachments, larger detachments with late presentation, you can do something called venting. And this is important because this releases the amount of fluid in the interface. You can use SF6 or air, and of course the post-op management is quite similar. Now, in hydrops, when you have significant amount of edema, Dr. Chaurasia described a continuous compression sutures, which actually works well. I will, and the concept is basically to squeeze out all the fluid from the interface. You can take full thickness sutures as well. Avoid, of course, the visual axis. And in fact, on table, you find a lot of them actually start clearing up. Now, the aim is basically to make sure that the fluid in the cornea comes out very, very significantly. You can use air. I prefer to use SF6 for large detachments like the patient that I showed you on presentation. If you've got full thickness perforations and if you have actually relaxed the cone, a good idea would be to actually use glue. Now, immediate post-op, and this is 2 hours post-op for the patient which I actually did this procedure, you can make out that the amount of fluid has come down very, very significantly. The fluid caps have come down almost to probably about 50 to 60%. And if you maintain the position, and this is the next day post-op, you can make out very, very, very good clearing of the cornea. The the cornea actually looks quite well. Only central edema where there is very significant breaks in the descemetes, and this usually takes roughly about 4 weeks to 5 weeks to actually clear up. And if the central visual axis is clear, these patients actually do well with the scleral contact lens. So that would be my preferred procedure. If the visual axis is not very good, then you're probably looking at a keratoplasty. This is just to show the first day post-op of the OCT. You can make out there is absolutely no descemet's detachment now. The stroma has actually become very, very compressed, and patient's vision also tends to be quite good. Just to reconfirm the take-home pearls, you need to have a good preoperative assessment. You need to look at etiology. Remember that surgical and non-surgical etiologies are different. Per-operative planning, especially with respect to the site of the incision to insert your descemetopexy cannula, is important. Post-op management, like management of the positioning, is important, usually 2 to 3 hours to make sure that the tamponade is effective. Remember that a lot of them, especially for delayed procedures, may require a secondary procedure or with repeat injections. So if you really want to break it down, it may be a good idea to try with air first and then think about SF6. Thank you so much.
Thank you, sir, for the excellent presentation. I have a question. When you do a decimetopexy post-cataract surgery, do you prefer to make a side port and go through a cannula, or can we just use a
30 gauge needle? That's a good question. If it's a cataract, I think you could use the side ports. But if you have a good 30 gauge needle, if you're injecting gas, I would suggest use a 30 gauge needle because there's no fish egging. Just a hack that if you got multiple bubbles, just use a bud and just tap the sclera. Usually just it coalesces into a single bubble.
Okay. So would you open up the previous side port, sir, or make a fresh one?
If it's within 2 or 3 days, you'll know within a week it's really not a problem. There may be very mild epithelialization over the side port, but usually is quite effective.